Good evening, everybody, and thank you to Dr. Nag and Dr. Gupta for having invited me here today. I'll be presenting two papers, which one is a prospective study and one's a randomized controlled trial, which both looked at the same question that can radiation be omitted after breast conserving surgery in a favorable subset of patients. Now, a quick background on what the evidence is for giving radiation after BCS. It's something we all know, that there's a 3 times higher chance of local recurrence in the group as a whole after BCS if radiation is omitted. What you can see over here, and that translates into a small but a statistically significant survival advantage in the group as a whole. And this comes from a bunch of different randomized controlled trials. The trials where they looked specifically at elderly women with good biology tumors like the CALGB 9343, which I'll talk about in a minute, did not in fact show much of a survival benefit. And the EBCT-CG meta-analysis in 2011, where they pulled in individual patient data from over 10,000 women and the similar randomized controlled trials, showed that the survival benefit from radiation comes in only if there's over a 10% reduction in the local recurrence at 5 years. And they divided women as per the predicted absolute benefit into low, intermediate, and large risk groups. And the lower risk group, which you can see to the right of the screen, did not show a survival benefit at the end of 10 years. So the historical CALGB 9343 was a randomized trial which included over 70 years of age, stage 1 ER positive women, and they showed an 8% less local regional recurrence with radiation at 10 years and did not translate into a survival benefit of any kind. Another Italian study, which was randomized in fashion, showed in women above 55 years of age and less than 2.5 centimeter tumors, showed a local recurrence of 2.5% versus 0.7% without and with radiation respectively. Again, no survival benefit. And the BASO-2 was a trial after BCS which showed with plus or minus radiation plus or minus tamoxifen in a 2x2 factorial design, which showed in the group, which you can see in the graph here, in the group that received both treatments, both radiation and tamoxifen, had a 0.2% local recurrence rate, which did the best up here. 0.8% local recurrence rate when either of the treatments was selected, and about a 2.2% annual risk of local recurrence if it was just breast conserving surgery. So coming to these two papers which we are going to discuss today, the first was from a Canadian group, which was a prospective trial of 500 patients with a median follow-up of 5 years. They were very strict with their inclusion criteria. They allowed women above 55 years of age, only grade 1 and grade 2 tumors, which were T1, less than 2 centimeters in size, and were truly luminal A. So these were at least ER, at least 1%, above 20% PR, HER2 negative with a Ki67 of less than 13.25%. They did not include multifocal DCIS with EIC, lobular carcinomas. They did not allow any LVSI either. And they were very strict with their quality assurance. They had a central review both for ER and were very strict with the Ki67 as per the international working group recommendations. And they had an excellent endocrine adherence of which was 82% at 5 years. So this was the prospective trial. And I've also shown on the right of the screen the PRIME2 trial, which was the other paper, which was a Scottish group, which was randomized, and it had about 1,300 patients in each arm with a follow-up of 9 years, median follow-up of 9 years. Now, they allowed slightly older women with an average age above 65 years of age, and did allow grade 3 tumors, although those were very few patients. They allowed up to 3 centimeter tumors and ER positive patients, and they later divided them into ER low and ER high based on the staining on the ALRED score, and they had very few patients belonging to the ER low group. They did not look at Ki67, and they did allow either LVSI or grade 3, but did not allow patients that had both of these high-risk features. The radiation in this randomized trial was pretty standard. It was either conventional or moderate hypofractionation, and about 15% patients received a boost, which was either with electrons or an interstitial brachytherapy. Their endocrine adherence was about 60 to 70% completed endocrine therapy at 5 years. So the results from the Canadian prospective trial showed that at 5 years, there was about a 2.3% rate of ipsilateral breast tumor recurrence. And so there were 10 true local tumor recurrences, and 4 of these 10 were more than 2 centimeters from the tumor bed. So these were probably new cancers with a better prognosis, and a 1.9% of the patients had contralateral breast cancer. None of these patients had regional recurrences, so any recurrence, so including the local recurrence and the distant metastasis rate, was 2.7% at 5 years. The results from the Scottish randomized trial showed at 5 years there was a 4.8% local recurrence without radiation, which proportionately increased to about 9.5% at 10 years without radiation, and it was only 0.9%, less than 1% when radiation was given. When they later looked at the subgroup of patients which had a low ER, they showed that there was almost a 19% chance of local recurrence at 10 years in that group. Again, no survival benefit from radiation. It was identical in both the groups. And in the group, although it was not statistically powered to answer this question, there were 4 times higher local recurrences in those patients that were non-compliant to tamoxifen. So almost all of our standard guidelines do endorse the omission of radiation in this group of elderly patients with a good biology. You have the European guidelines which say that it's safe and a reasonable option above 60 years. The NCCN guidelines say that you could consider omitting it above 70 years in stage 1 ER positive, but they should be taking hormonal therapy. You have the St. Gallen's group which supports it. But again, those who are going to be adherent to adjuvant hormonal therapy only, or those who have shorter life expectancies. Our own National Cancer Grid also does endorse this as per the Prime 2 criteria, and the Spanish guidelines which also endorse it as a considerable option. But with all of this evidence and all of these guidelines, how wisely do we actually choose? So the real world situation is that in this study, which came out in 2019, it showed that still 75% of women belonging to this particular subgroup between 70 and 75 years of age still do get adjuvant radiation, and about 50% of patients who are 75 to 80 do get adjuvant radiation. So we will know in our panel discussion what people are practicing and how wisely do we choose, how many patients are we over-treating. The unanswered questions are that what do we do with other soft indications, so lymphovascular invasion or grade 3 tumors. These trials and these studies did not have enough patients to answer this question. Can you safely omit radiation in such patients? We don't really know. Ki-67, again, as we know, we have to be very strict about the standardization and the reliability of Ki-67 and its cutoff values. Can genomic assays help us to make this decision? We earlier today saw the IDEA trial, which was published in December last year with a 5-year follow-up in these patients where they used Oncotype DX and showed a 3% ipsilateral breast tumor recurrence. Earlier today, we also saw this 16-gene assay, which is called the POLAR assay, where they looked at this as a tool to help guide the decisions for omission of radiation in patients. Again, not routinely used in clinical practice. And these are a bunch of different studies. The Lumina A is the Canadian study and the Prime, the Scottish study, but we have the IDEA, which I spoke about, and a bunch of other studies like the EXPERT, the DEBRA, and the Europa, which are looking at using genomic assays like the Oncotype DX or a PAM50, and also answering the question of partial breast radiation. So these are the studies to look out for. My take-home message is that if you're looking for a reason to omit radiation in a patient because of logistic issues or because of decreased life expectancy from comorbid conditions, then sure, we do have good evidence to safely help us make that decision. But if it's just logistics or fear of side effects and morbidity that's a concern, then we have partial breast radiation, we have ultra-hypofractionated schedules, which can make life much easier. In a carefully selected subgroup of patients, radiation may be omitted after breast conservation, provided there's good compliance to follow-up and hormonal therapy. And this decision has to be a shared one with the patient after a discussion, with the acceptance of a small but a significant increase in rate of local recurrence, which does not impact survival. So the question really is that tomorrow, if you have a patient in the OPD, she's 70 years old, she's fit and active, she's likely to live for another 15 years with a screen-detected luminal A post-BCS, and she says, I'll do whatever you suggest. Are you going to give her just hormonal therapy, or are you going to give her the best and the easiest possible radiation you can? And I'll leave it at that. Thank you.